Good evening, everybody, and welcome to our event this evening called The Role of Midwives in Perinatal Mental Health, brought to you by the Motherhood Center. I want to welcome everyone who's joining us tonight. My name is Paige Bellenbaum. I am a social worker and I'm the founding director of the Motherhood Center. And I'm very honored to welcome Risa with us this evening. I'm going to get to her bio in just a moment, but I wanted to go over just a few ground rules first and also let everybody know a little bit about the Motherhood Center and who we are and what we do. The Motherhood Center, for those of you who are new to our work, we have been around for the past 5 years. We are a facility that provides support and clinical treatment to both pregnant and postpartum women and birthing parents that are experiencing what we call perinatal mood and anxiety disorders. The acronym for that is PMADs, and it's what most people know of as postpartum depression or the postpartum, but it actually includes a whole host of different diagnoses, including depression, anxiety, obsessive compulsive disorder, post-traumatic stress disorder, bipolar disorder, and in rare but very serious instances, psychosis. These are all different types of symptoms and diagnoses that a large percentage of new and expecting mothers experience. The average is about 1 in 5, but since the pandemic began, there's been a lot of research across the globe that has suggested that those rates have gone up as high as 70% of all new and expecting mothers. So at the Motherhood Center, we aim to provide relief to women and birthing parents that are experiencing PMADs, and we do it through support groups. We do it through outpatient treatment, including therapy with a perinatal mental health specialist or a reproductive psychiatrist that specializes in medication that's safe and effective to take during pregnancy and while breastfeeding. And we also offer a very special level of care called our day program. And this is a program for perinatal women and birthing parents that are having a really hard time making it through the day, caring for themselves and or their baby. And it's a more intensive level of care, but the beauty of it is that it helps new and expecting mothers and birthing parents feel much better, much faster. And one of the other things that we like to do is provide education to both providers and also new and expecting mothers and others that are interested in learning about the intersection of PMADs and so many things. And we do that through our monthly provider seminars, which is why we're all here tonight. So just a few of the house rules for tonight. This event is being recorded. So if you're joining late or you have to leave early or you want to share it with a friend, we will be emailing it to everybody who registered. We'll probably be sending that out tomorrow or Thursday at the very latest. As far as questions and answers, please feel free to put those in the chat. I will be going through them throughout the event this evening and pulling pertinent questions for Risa. And then we'll also save some for the end so that we'll get through as many as we can. And if for some reason we can't get to all of them, Risa has generously offered to answer some of those after the fact. So we can send those responses out as well. And we will be sending out an email, like I mentioned, and it will include both the recording, contact information for Risa. She'll be referencing some research this evening that will also include in that email, so you can read more about what she shares with us tonight. And also a couple of videos, one of which we'll be sharing with you tonight about Risa's great work at Northwell. So without further ado, it is my absolute pleasure to introduce to you Risa Klein. Risa is a highly skilled, experienced, and intuitive midwife licensed by the state of New York and New Jersey as a certified nurse midwife, as a nurse practitioner in obstetrics and gynecology in New York State. Risa is the director of midwifery at Lenox Hill Hospital in New York City and holds an academic title of assistant professor at the Zucker School of Medicine, Hofstra University, Northwell. She's a member of the Katz Institute of Women's Health. She offers her home-like approach on the labor and delivery floor, teaching residents and medical students the important work that midwives do. As a solo provider, she's practiced in a variety of settings, including hospital labor and delivery, in-hospital birth center, and home. She collaborated for 15 years with the late Andrew Garber, Dr. Andrew Garber, a high-risk perinatologist and OBGYN with hospital privileges in 4 New Jersey hospitals where he ran the maternal fetal medicine units. Risa graduated from Columbia University's School of Nursing, receiving a Master's of Science degree in nursing with a specialty in midwifery and a Bachelor of Science in nursing. Risa enjoys being a grandmother to her 7-month-old grandson, Noah, playing piano, cooking, and working on her book about the emotional dynamics of childbirth and how they impact labor outcomes. She is passionate about midwifery care as a means to reduce unnecessary interventions and cesarean sections, thus improving maternal and infant health. Risa, it is such an honor to have you. You are somewhat of a famous figure in the field of midwifery here in New York. So we are just tickled that you're with us here to talk all about the great work that you do. And I'm just going to jump right in if that's okay. And Risa, tell us, what do midwives do?
Oh, that's the $1 million question, because I think if everybody really knew what midwives do, we'd all be using one. You know, midwives are with women. We work from our heart. Nurse midwives and certified midwives are accredited from the American Midwifery Certification Board. We go to accredited university or college, and we earn a master's degree in midwifery. So we're skilled, we're smart, we're very intuitive, we have heart, and some midwives are nurses, some aren't. But what midwives do are a variety of things across a woman's reproductive lifespan. And my goodness, one of my roles at Lenox Hill Hospital is training the third-year medical students at Hofstra what midwives do. Because how does any woman enter the reproductive world? Getting her first pap smear, Paige. How does she receive her first mammogram? How does she learn about birth control options? It's usually through a gynecologist. However, midwives are trained in well woman care, providing women with well woman care, annual pap smears, breast care, preconception care. Midwives take care of women, again, through the reproductive span, through conscious conception, nutrition counseling, modification of life, wellness care, pregnancy, labor, birth, postpartum, the 4th trimester after, and then we take care of her in between until her next baby, if she chooses. So that's what midwives do. We take care of women. Now, the interesting things about women that they should know is that we take care of healthy, low-risk women. We do not take care of, for example, women that have heart disease, liver disease, kidney disease, some blood coagulation disorders, sometimes when a fetus is a very high-risk condition. However, midwives can manage some high-risk women, and we do it with collaboration, consultation, and co-management with maternal fetal medicine physician. So that's who Dr. Garber was. And at Lenox Hill, we work with Dr. Shane Wasden. So midwives refer, we recognize when women fall outside the scope of normal healthcare. So midwives see women's healthcare as wellness, as opposed to the obstetrical model, and we need obstetricians, but there's surgeons. So they take care of women when they do have medical risk factors. So midwives are with women, taking care of them, and I am so excited to be here because a lot of people don't know that. Midwives also do VBACs, vaginal birth after cesarean. We co-manage with a consulting maternal fetal medicine physician. Midwives, such as myself, also we deliver twins as well. So we also take care of IVF patients. We also take care of women from puberty through menopause. We take care of women in their breastfeeding, in their postpartum care. And I think that what's quite relevant is the close relationships of trust that midwives have. We have the teacher of time, if you will, that we can establish relationships, and research shows us that women do much better with with midwifery care once close relationships of trust are established with women, and they feel that.
Risa, thank you so much. I mean, as you're talking, it's like midwives do everything, right? They're super women to some extent. I'm assuming most midwives are women. This is not to be
That's a
discriminatory.
very good point. There are some that are men, absolutely.
And so I've shared with you, Risa, with my two children, both, I birthed with a midwife. And I put a lot of time into making that decision, and it felt right for me. And I was incredibly happy with both of my birth experiences. In your opinion, who is the right midwife client?
Yes. So it's a really great question. And I'm going to put it back to you.
Okay.
What made you choose a midwife? And then we'll talk further.
So when I was researching my pregnancy experience, my birth experience, I really wanted to have somebody that was extremely accessible, someone that I could establish a more intimate and emotional relationship through, especially my first pregnancy. Me being somebody who's very open about my own mental health and having a history of anxiety, these things felt really important to me to have that type of connection through my pregnancy and birth and postpartum. I wanted to have that sense of when I was in a visit with my midwife during my pregnancy, that I didn't feel that sense of like the time clock ticking, that I could feel comfortable asking all of the questions that I had, and that that I'd be able to have that relationship doing something that I'd never done before that felt really scary to me, and just knowing or feeling as though there would be that kind of sense of maternal caring throughout the process. So those are some of the things that went into my personal choice.
Yes. So that makes you the right midwifery mama, right? By the way, I don't wear a watch. So you intuitively, who is the right midwifery mama? Okay, who is she? She really is somebody who is very much aware of her body. She's very cognizant of her breathing, her body. She might be the kind of person who exercises, or she might be the kind of person that doesn't exercise. She might be the person who, like you, feels more anxious, or had felt anxious, or is concerned or worried and wants to be an active participant. So I would say one of the number one characteristics of midwifery clients, I'm doing this almost 30 years, is somebody who wants to be an active participant, somebody who wants to get educated, somebody who wants to feel validated, somebody who might have a history of any kind of trauma and want to be able to finally disclose that trauma or that event to somebody. Because what I know, that's something very important and near and dear to my heart, is that what's unaddressed in our lives will emerge, the trauma will emerge during labor. And even if it's not addressed, midwives are the kind of provider that are intuitive, that will ask questions, that will spend more time with a woman, asking her about, how do you feel? What have you been eating? So that is the kind of woman who is yearning to have that kind of open communication with a provider, and not somebody who, okay, very good, thank you very much, see you next time. So the midwifery mama is somebody who wants to be heard, wants to disclose, wants to feel safe, and she wants to feel that she has a say. And if you read a lot of the research, whether it's from Denmark to Ireland, Germany, I mean, in terms of patient satisfaction, not only does the mama who has the patient satisfaction working more so with midwives, but they're less apt, even in um, um, socioeconomic groups that are perhaps lower than others. They have less preterm labor, less preeclampsia, more satisfaction, less induction. Why? Because they're listening to their midwife. They want to learn. So if you're the kind of person that wants to learn how to take care of yourself and you're gestating a baby, then you again might be the kind of person to want to pick a midwife. Somebody also who truly wants to have a vaginal delivery. Now, let's not kid ourselves. Challenges could occur even with a midwife for a mama or a baby, and she might need a cesarean. But every step of the way, if you pick a midwife, you will know your midwife would be with you. You would have that information, validation to know that your midwife wants to know about you. So, wanting to be heard, wanting to be an active participant, wanting the truth, wanting to be called out, wanting to learn, birthing a baby is 2 steps forward, 1 step back. We grow up. So somebody who really is seeing, from my point of view, that birth is truly a catalyst for growth. So that's the way I see women, wherever you live, finding a midwife. And again, if you're low risk, if you do not have a high risk medical disease, then you would be the right candidate for midwifery practice.
So you hit on some really important things as we intersect and kind of make our way into the connection between midwifery and mental health and PMADs in particular. One of the things that you started with in response to this question was the experience of trauma. And something that we see every single day in the women that we treat at the Motherhood Center is that intersection between trauma and mental health. And it's heartbreaking and unfortunate and also factual that so many women, almost, I think some statistics suggest 50%, have experienced some type of physical sexual trauma in their lifetime. And to your point, the very act of becoming pregnant, being pregnant, giving birth, breastfeeding, these can all be very activating experiences for a woman who's experienced any kind of physical or sexual trauma. And for someone to be trauma informed and to create a safe and open space for a woman to feel a sense of autonomy and ownership over her own personal experience and how it shows up in the perinatal period, and to have somebody who's willing to really take that in, understand it well, and accommodate the needs of that woman through her perinatal experience, because it does require some accommodations. As I'm sure you are very aware, there are different ways that we can speak to a woman who has a history of trauma. There's ways that we can involve her more in the outcome of her birth and everything that surrounds it. And so having said that, both, through a trauma lens, but also kind of moving more into the emotional support and experience of what midwives bring to the table, how do you see that connection between midwifery and maternal mental health?
Yes. Oh, God bless you. Yes. Thank you. It's profound. It's profound. I believe that many women who have suffered prior PMADs or other mental health challenges seek out midwives specifically because they're yearning to not have trauma. So if you read the research, I mean, I'm really blessed now. For a little over a year, I've been at Lenox Hill Hospital, and this is the 6th hospital I've worked in. We have a new chair, Dr. Frank Chervenak. Dr. Shane Wasden is the maternal fetal medicine physician. And with these people, with these physicians, we've done research. I've been on a team where we've known this from other research, that where you have an increase in midwifery attended births, you have a decrease in cesarean section. So we're looking immediately at a surgery that creates trauma. And I believe over the years, what I've found the most relevant fear that women have that I've asked over the years is, I'm afraid I'm going to have a C-section. And I'm afraid that something, God forbid, will be wrong with my baby. Those are the two fears. So why is that? Well, we love our babies and we don't want to have operative surgery. So from a mental health standpoint, if women understand they're less likely to have interventions and cesarean section, then a midwife would be the right provider for them. Again, provided they don't have a high risk factor. So that's a huge component of reducing mental health PMADs for women to have to cope with, because midwives are really, because it's a more holistic, like looking at the gestalt of a woman, I look in her eyes, but what did she do yesterday? What is she thinking about tomorrow? What did her doctor or midwife tell her at her first birth? So this all has to do with her mental health. So I believe that the connection is profound, because if you know you're less apt to have intervention, you're less apt to have somebody telling you what to do rather than involving you as a participant, as a team member, then you know that you're going to have a more empowered, fulfilled birth experience. And that's probably, Paige, what you were looking for as well when you picked your midwife team.
It absolutely was. And, all the things you wish you knew going into your first birth, and then you go on to have a second or third, and you make different decisions, you make perhaps better decisions because you know what to expect. But yes, to your point, I thought I knew a lot of things going into it the first time. I realized I knew very little, and the second time I knew a lot more. But to the best of our ability, yes, we do want to feel like we have more autonomy and control over the situation. And, to your point with, the potential to experience a C-section decreasing significantly. And as you mentioned, there's volumes of research that suggest this. I want to substantiate that with the women that we treat at the Motherhood Center. So often, with the experience of a traumatic birth, be it a C-section or some other type of intervention that a woman wasn't necessarily planning for or thinking would happen to her, because we never think these things are going to happen to us going into it, that experience in and of itself, the trauma of it, can be a trigger and or can open the floodgates for a PMAD to develop, right? A sense of health anxiety a woman can experience almost immediately after an emergency C-section, right? Like, what just happened to my body? Can I trust my body? Not being able to recover quickly, but still having to care for an infant. These things can really lay the groundwork for heightened anxiety or the onset of depressive symptoms. On top,
It's
yeah,
also a great loss, an unexpected loss. So there's grief.
yes, absolutely, absolutely. I can't tell you how often I and other clinicians who work in the field of perinatal mental health give women permission to grieve the loss of the birth that they wanted and didn't have, right? Or to grieve so many things that happen either through the attempt to become pregnant, through, one or more failed IVF treatments, to miscarriage and loss that then led to a pregnancy that came to full term and delivery. Like, all of these things, we don't provide enough space or room for women to process, grieve the loss of. And so being able for a woman to feel safe enough to bring all that into the room and to have that all be taken into consideration, I think is really one of the most holistic and empowering things that a woman can feel and experience.
Yeah, absolutely. I mean, and one of actually the VBAC mama, who we have that little video if you want to show, I think it's a really profound message of a woman who had postpartum depression, had a cesarean, didn't feel that she was involved. And then she made an effort and somehow found me and she was the first delivery I actually did an unmedicated VBAC, no less, at Lenox Hill Hospital, and this is a hospital that was known for high intervention, and having now the midwives come, we're working hard, we're actively involved in changing the face of this. And I'm just wondering if it's something maybe we want to show of what happens when somebody has grief and then heals.
Let's do it. I know Shannon has that short clip ready to go, so let's take a watch.
I have two kids, one newborn named Daniel and another one, Joey, who is 3.5 years old. My first birth experience was a little bit traumatic. I ended up with a C-section after trying to labor for quite some time, and it ended up just a long process of healing, which took away from bonding with my child. For the second child, I really was looking to have a natural birth experience, and I remember that midwives are usually very supportive of natural birth, and in my case specifically, this had to be a natural delivery after a C-section.
Olga reached out to me wanting a VBAC, a vaginal birth after cesarean. She wanted to learn how she could have a new kind of birth experience.
Having a midwifery service here at Lenox Hill is an invaluable component to our mission, not just for education, but for patient care and for research.
The benefits to midwifery care are pretty well studied. Studies in the United States have even shown lower rates of cesarean delivery with midwife-led care.
As a woman's primary care provider, midwives are able to take care of healthy, low-risk women, and if a challenge emerges, then we can refer accordingly. So women want that kind of all-inclusive care and teamwork in their healthcare professionals.
Since the midwifery program has started, there's a lot of enthusiasm from the nurses, also from the attendings and from the residents, just to have a new type of provider on the labor floor and a new model of care.
What most surprised me about the midwifery care is this holistic approach, and that's the amount of time dedicated to you as a patient. I think this kind of emotional, psychological support is incredibly important for expecting mothers.
Those mothers who choose this feel there's a much stronger bonding with their soon-to-be-born child and their newborn infant, and it's a beautiful experience.
My birth experience was really like a dream come true, and I really credit everything to Risa. Risa was supportive of anything I wanted to do. It really just turned out just the way I imagined.
Risa has been embraced, and the ideas that she has are being brought forward, and I see this program growing in the months and years ahead.
This midwifery program is looking to encourage women to know that they have choices, that there are midwives here now at Lenox Hill Hospital that can give them a more holistic alternative, that they could feel the confidence that they're being well taken care of. It's just such an honor to be able to serve women as their midwife.
That is so beautiful, Risa. What's it like for you to see that and be like, I birthed that baby?
Oh, I have goosebumps. I have goosebumps. She is extraordinary, but every woman can be just like Olga, because she didn't know, like you said, Paige, with each birth, we gain more wisdom with each birth. And your midwives help you learn about who you are. You know, it's like our old self and the new self. And here we're seeing Olga hear about, yes, it was traumatic and I needed something different. She might have said that she credits Risa. I mean, I'm honored to be her midwife, but it's her. She did the work. She found a new solution for her newer self. And that is what's important about women and mental health. Because if your trauma was a cesarean, for example, a midwife is more apt to talk with you and reframe it, go over your medical records. Midwives also can do consultations. Doesn't mean you have to work with that specific midwife, but there's a new approach, like you used earlier, looking at the lens. Let's look at the lens of how your birth experience unfolded through a midwife's eyes. Often it has to do with something that a woman might not even be aware of. Like, I have a lot of people that fly from around the world to work with me, and one woman's first birth was in Brazil, and she didn't want to have a birth like that. It turned out she was very concerned about having her baby. What did I learn? In her country, after the baby is born, they take the baby away. When her baby was returned to her hours later, she had to ask the nurse, is this my baby? She wasn't sure. So for her birth with me, I made sure that no nurse went near her. This was not at Lenox, so it was in another hospital. And the baby went right on her chest. Nobody was I wasn't cutting the cord. The baby was staying on her. And then she told me, she was crying, that she healed that wound. So another birth experience that's positive, like Olga's, could really heal that wound.
Mm. It's true. You know, I run a group at the Motherhood Center called Having a Second After a PMAD, and it's for women that had postpartum depression or another perinatal mood and anxiety disorder the first time, but are really looking to have a different experience the second time. There's so much more perspective. There's so much more ability to recognize one's power and the ability to kind of plan, but also be more flexible, but realize the role that they can play in the overall outcome. And so, you know, being able to say things like, I know what contributed to my PMAD the first time, and these are the things I want to do differently the second time. So for this particular patient you're referring to, and what happened to her the first time of not even knowing if that was her baby or not, to be able to say, I want my second birth to look like this, right? Like I have the power, control, and autonomy to make that decision. And it sounds like, and this is not to say that OBGYNs wouldn't also be accommodating, but like just this whole concept of holistic care, right? Like taking in every wish and piece of a new and expecting mom at the same time to contribute to that birth outcome is, it can really make all the difference in how she experiences her birth.
Yes, absolutely. And I want to add something about the partners, because there was a study done regarding in Copenhagen, in Denmark, where they did a Facebook study where they interviewed the men and they had them fill in the Edinburgh postpartum depression scale. And the men whose wives worked with midwives, less PMADs for them too. You know, and you know, I could tell you hundreds of stories, but I had a wonderful woman who, you know, was very anxious after she gave birth. She was traumatized. She didn't even understand why. And she heard about me. We did a lot of counseling and reframing it. And what she realized is that when she was laboring, she wasn't really in her body, and she was anxious and didn't know why. And I asked her, where were your thoughts during your labor to help heal the wound of her anxiety since she gave birth? And she said, you know, my midwife never asked me that thought. You know, where are your thoughts? I said, well, I'm asking you now. What were you thinking? And then she said, I felt like I was high. I was addicted to opioids. I had substance abuse. And I didn't realize, now that you mentioned where my thoughts were, that's how I felt. Well, for the next delivery with me, she didn't realize she was laboring as a drug addicted teenager when she broke her leg and needed opioids. And then, you know, so for this labor, we reframed it that she was going to get a doula, which she didn't have the first time. We love doulas. I really believe doulas working with midwives are the A team to help reduce PMADs. And for her second birth, she shared after her birth, and the mantra was, "I'm here with my baby." So she wouldn't go back to any other thoughts. The mantra became, "I'm here with my baby. I'm here with my baby." And after the birth, she said to me, "I was in my body." At my first birth, I realized I was hovering over my body like when I was a drug addict.
Yeah.
That was so healing, also for her husband. So, when we talk about reframing loss or trauma, including the men or the partners, that it's interesting that midwives even help with the education and empowerment of the partners as well, because midwives are also, I think, more nurturing in that way. And just to give you an example, one of my women was laboring and she was working hard. And I said, "You're amazing. I love you." And I love her, one of the residents, third-year residents, whispered in my ear, "Risa, did you just tell her you love her?" I said, "Yes, I did. And you could try it one day." And she said, "I will. I've never seen that." So when you talk about love and nurturing and more holistic and seeing this, it's almost, I think many midwives would agree with me, that we see ourselves as aunties or family. And when we need to refer or consult with, for example, what I do now, and Alexandra Black, who's the midwife that also works in our practice, if we have a challenge, if somebody is on medication, you can work with a midwife if you're taking medication. You would just consult with our maternal fetal medicine physician in terms of dosage, etc. So many women should also know that you can, even if you have are on medication, you can work with a midwife, with a consult, with a high-risk physician. So wherever women might be living, they would find a midwifery practice that has a consulting and collaborating physician for those reasons. But yeah, so I think a lot of midwives really see themselves as nurturers and trying to identify the trauma before labor.
Right.
And
One of the things that is gaining more and more attention, thankfully, is the insanely high maternal mortality rates in this country, particularly for women of color. In a lot of the research that I've read, we have some of the highest rates in the world, as one of the largest and most powerful countries in the world. It is abominable that this is our truth. And I'm wondering what role does midwifery play in lowering those maternal mortality rates, particularly for women of color?
Yes, they absolutely play a role. Research shows us this. I will bring up the late Dr. Andrew Garber, because I worked with him for 15 years. And he boasted and he took all insurance, but Medicaid. It was mostly African-American women of color and military families, and all women really, but we had a large Medicaid women of color population. And by bringing me on, he boasted the lowest cesarean section rate in Bergen County. Why? Because what do midwives do? For all communities, especially women of color, the most important question, Garber would say, go down to climb, if they wouldn't gain weight, for example. The most important question any provider, the first day you meet a woman, is, tell me what you're eating. That will give you a clue of how her pregnancy is going to unfold. And if she's having soda and chips and not eating protein, you know that she's going to end up down the road in either preterm labor, gestate a small for gestational age baby, release her water early, go into preterm labor, and end up with a baby in NICU. So we were very blessed that nutrition was the hallmark. Protein, 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 salting your food to taste. Dr. Thomas Brewer was a very important physician way back when, and he came up with a Brewer diet. His daughter Gail continues the message of protein, eating 2 eggs a day like they're vitamins. This in and of itself is the way we keep women healthy. So I believe that the midwifery model of care, which not only focuses on nutrition, eating protein, and really going over nutrition, what a woman's eating, or we should be, is also modification of lifestyle, environmental hazards, going through this. And Paige, I might have shared this with you, but we had a young, beautiful little Black teenager who was pregnant and wasn't gaining weight. Garber sent her down to me, and I loved her army fatigues that she was wearing. I needed to start bonding with her. So this is what midwives do. We try to bond. She wasn't making eye contact with me. And long story short, she had pica. When I finally told her I loved her army fatigues, and then when I had asked her, what are you eating? She told me that she's eating sand and clay. And I gave her a hug, and she let me, and she started to cry. I said, let's talk about what we can eat. Do you like the taste of sand and clay? Do you like Dunkin' Donuts? She's like, yeah, like she's almost shocked that, here I'm talking about protein and I'm talking about donuts. I said, why don't you go and buy the sugar-coated donuts that you'll be able to feel in your mouth. It'll taste like the sand. And there's eggs in Dunkin' Donuts and milk, and you'll be taking care of your baby. Well, 2 weeks later, her mother came with her, gave me a hug. I could still feel how hard she squeezed me, and her daughter finally gained weight. She said not only is she eating the donuts, but she really liked them and is now eating 2 eggs a day, just like you recommended, Risa. So this is what we need to do. Midwives can help. I believe that there just needs to be, when we talk about challenges, more collaboration like we have, like I have with Dr. Wasden, working with women, working with medical students, teaching them about midwives do, and hiring more midwives and doing programs like this that more women realize, well, wait a minute, I'm 40, I had IVF. I can work with a midwife. Right now, we've got 3 or 4 women over 42 years old. A few of them are IVF. One is going, Alex just delivered a VBAC. She was 41 or 42. So there's quite a remarkable relationship between midwifery care and reduced small for gestational age babies, reduced intervention, reduced need for inductions, reduced PMADs after delivery, because breastfeeding and bonding, if a woman is unable to, chest feeding, midwives are very, very cognizant of keeping mothers attached to babies. At my delivery 34 years ago, I didn't have a midwife. I didn't allow the doctor to cut the cord, until the cord stopped pulsing. He said, what do you mean? And so I believe that the more women understand that midwifery care, even in populations that are challenged, inner city, I worked at, an inner city in Passaic, New Jersey, and I had beautiful birth outcomes with my clients. So I really believe that we can reduce these rates by talking about nutrition. That's the most important question. I have women fill out a nutrition menu before they even come into my practice, so that I can help them the very first day I meet them, to make sure that I know women that don't gain weight in their first trimester will often have low amniotic fluid level in the 3rd trimester, And guess what that equals? Premature labor or induction. So midwives are very aware of trying to keep women healthy and out of the operating room with these principles in mind.
So Risa, what are some things that moms can do to be proactive, planning ahead for their conception, early pregnancy, or transferring providers? Like, is there some kind of a checklist or what are your suggestions in that regard?
Yeah, I think, and we could even put together a checklist, for whoever's watching. But yeah, I think that the first thing is identifying your needs, like literally writing out your list of what's important to you. I have a series of questions that I ask my clients. I call it the miracle of birth once again questions. And one of the most important questions is, if there's one thing I wish I would have told my doctor or midwife is ... Fill that in. If there's one thing I wish I would have told them, because that's part of the trauma. That's the root of the trauma. And if I could have changed, second question to answer, if there's something I could have changed about my birth, what would it be? These are the two answers you bring when you do your research interviewing your midwife. Okay, so that's very important. Finding a hospital in your neighborhood that not only has a midwife, but has a collaborating physician that she's close with. So like this, like two peas in a pod, because if a challenge emerges, then we need to collaborate with that physician. So finding a hospital, finding a hospital with a midwifery practice that has the collaborating relationship. And you might even want to interview them all. I think it's very important to interview the midwives and interview the collaborating physician so there are no strangers at your birth. So that's something else that they should take to heart. I would fill in your nutrition for a week. Breakfast, snack, lunch, snack, dinner, snack. Protein is the hint. Protein will keep you out of harm's way. Salt your food to taste. This way your midwife could review with you what you've been eating. Something else they could do is, if you haven't had a pap smear in 2 to 3 years and you don't know what your result was, find your records. If you've had a prior cesarean section, get your records, get your operative report. You're going to need it for potential TOLAC, trial of labor after cesarean, and then a VBAC, vaginal birth after cesarean section. So you put together your resources, you put together your list of paperwork for your potential provider. I would also ask yourself, did I have a doula at my first birth? And if not, I would start researching doulas as well. And I would also, when you do your research for a midwife, find out if they do counseling. And if not, the Motherhood Center is where you should be getting your counseling as well. If you have a psychiatrist, you want to make sure that you have your medication regimen and also notes from your psychiatrist, because you're going to need that when you go in for your visit with your midwife. So these are some proactive things that I believe every woman should do when preparing for the next, what I like to call conscious conception. And doing a well woman pap visit, just coming full circle to that, is a great way of meeting with a midwife and seeing if you bond. And then you stay connected, and then you are going right into her care.
You mentioned a couple of times partnering with an MFM doctor, and I would imagine that sometimes this question comes up quite a bit because there are many myths that are associated with midwives, which you touched on a little bit, but would be curious to hear a little bit more about what those myths are. But what happens if there is a complication during the pregnancy or the delivery when one is using a midwife?
Well, that's an excellent question. And it was just almost hot off the press. You'll be if we show it, it's like a little 3-minute myths about midwives. That might be a good one to show too. if God forbid there's a challenge, so again, we have 24 midwives in all hospitals should have 24/7 obstetricians on the labor and delivery floor. But during the antepartum care, and I believe, I mean, right now I have a woman who has a small for gestational age baby. She has just 2 vessels in the core. The baby is small. She has other um, challenges. She's anemic, but I'm collaborating with the midwife's collaborating with Dr. Wasden. It's amazing. So in the event there's a challenge and a woman does, for medical reason, need a cesarean, the midwife is with woman. We call it a gentle cesarean. So the woman, if she needs a cesarean, either during labor, or let's just say there's another challenge that the mother, from maternal reasons or fetal reasons, needs a cesarean, the midwife will go with the mama and the partner in the operating room. After the baby is quickly evaluated, I take the baby over to mama, and she chest feeds or breastfeeds right on the operating room table. Midwife holds the baby the entire time on mama's chest. Or if papa or the partner wants to hold the baby next to her. So that's what would happen. And then postpartum, the midwife is right there helping with breastfeeding, latching on, and stays with mama until she goes to her postpartum room. And rounds on her as well. So even if you have a cesarean, the midwife will still see you in your postpartum. And there are also lactation consultants at our hospital, and I trust at most hospitals also around the country or world, wherever people are watching from. So I think that what people need to know is to reduce trauma, to reduce anxiety, knowing that your midwife, because let's face it, if you have a, obstetrician and they're doing the cesarean, the nurse is not going to be able to hold the baby with you, for 45 minutes. So that's a very special relationship that I think a lot of women don't realize will happen. But there are myths about midwives, and maybe we want to show the myth video.
I would so love to. I don't know if we're going to have enough time today, but we are definitely going to include it in the email that we send out, both a link to the video that we watched and that one as well. With just a few minutes left, Risa, I wanted to go ahead and turn to questions from the audience. So you don't have to worry about reading them. I will read them to you. And so we have a couple of questions. I'm going to start with a question from Celeste. Can you share thoughts on hospital-based midwifery versus home birth with a midwife? Highlighting key differences between the two and how to decide which location, home or hospital, makes sense.
Okay, thank you for your question, Celeste. So I did home birth for 10 years. That was the first midwifery practice that I had as a solo home birth midwife. I used to fly up to Michigan and do home birth. I did home birth in New York and New Jersey for 10 years. And then I realized that I was really lucky. I used to carry oxygen with me and medication, but I was lucky. I picked my clients well, but I believe the safest place for a mama and her baby is with a midwife, giving a home birth-like approach in hospital, because minutes matter. And, even at home, you still risk the possibility of being transferred anyway, you see. So I believe that the differences are really, midwives are the same, and I have a home birth heart and I bring it to the hospital. Minutes matter. Yeah,
minutes matter. That's a good thing. That's a good, what is it when you use 2 words that have the same letter? I'm not thinking well. Alliteration. I have another question specifically to this amazing program that you're overseeing at Lenox Hill. Does insurance cover a midwife at Lenox Hill or anywhere?
Oh, that's a really good question. Okay, so I'm not the insurance person. We do take insurance, but it depends on what the insurance is. For our midwifery practice, we're taking health insurance, we're in network, and we can give the email where people could write and share with our office staff about their health insurance. But it's not out of network, it's all in network.
Great, great. I have another question from Mylan. You mentioned the fourth trimester. How does a midwife help new mothers through their fourth trimester that's different or special?
Oh, Mylan. Yes. So the fourth trimester, the fourth trimester is so important because in order, midwives develop relationships of trust with their mamas and the papas and the family. So what happens is when a woman goes home from the hospital, we talk on the phone as many times as she wants to help with any questions she might have about breastfeeding or bonding or the family or incorporating a new sibling in. And then we see her at between 5 and 6 weeks postpartum. But we could see her whenever she wants. And then what I like to do with my mamas is keep in touch with them, often so that I see her for her next pap smear and then for her next pregnancy. So there's a lot of communication. I think that that's what makes it very different than obstetrical care. In midwifery care, you're not a number, you're a person. And we're able to speak with our mamas as often as they want.
So Risa, we're getting close to the end of tonight, and I'm just wondering, is there anything else that you want to share with the audience, perhaps something that you wanted to touch on, that you want to make sure people know about midwifery or any of the other topics that we've touched on this evening?
Yeah. Well, what I could say is that I became a midwife after being a television news producer, okay? I gave birth to my baby and I was really empowered. And it's true, I didn't know my doctor. He was the backup. He was looking at his watch the whole time. And my husband fought with him about giving me an episiotomy or not. But after I gave birth, it transformed my life. I realized that the most important thing a woman could do other than meeting her partner is bringing life into the world. And I wanted to make sure that I could be the guardian to that. And I think what women should know is that I'm not unique. People that go into midwifery really have a calling. It's not really a job, it's a calling. It makes you realize I want to be with women on the threshold. And I think many doulas become doulas also because they really want to help women. So I feel that there's an excitement that women can feel confident in their research for their next provider in getting the counseling, reframing past birth trauma, and being able to have an excitement about bringing life into the world. And it was the birth of my daughter that now has blessed me to work hard and help women as they usher in new life. So I think that women should know that about all midwives, that that's really our goal.
It's wonderful, Risa. And I think it's so informative to hear in such greater depth and detail the role that a midwife can play in the overall birth experience, just the perinatal period, how this holistic and maternal and available approach really can have an impact directly on PMAD rates and PMAD symptoms in the postpartum. As we know better than anyone else at the Motherhood Center, despite all of these additional supports and interventions, women still do experience PMADs. And yet, to be able to have a little bit more choice and accessibility and involvement from one's healthcare provider, in particular a midwife, it can absolutely and certainly help to have that kind of relationship, even in the event that a woman does experience a PMAD. And, one of the things that we could do a whole other seminar on is comparing the American healthcare system for women and just the maternal experience to other countries. And so when you talk in particular about the postpartum period and the accessibility and the availability and being there for women to ask questions to and to check in. When we look at some of these other countries that have all of these different practices, laying in for 40 days or having a nurse visit you at home the first week, right? Like, to know that there is a level of maternal health care that goes above and beyond the standard practice. It really, as we started, there is a certain kind of person for this level of care. And so you have done such a great job illustrating that for people that really are looking for this type of perinatal and birth experience and postpartum experience. Those who have joined and those who will hear this recording know that they have a choice. And I just want to thank you so much for your time and everything that you shared with us. And I want to let our audience know this recording will be going out. The research that Risa referred to throughout the presentation will, the recording that we saw, as well as the myths of midwifery that Risa mentioned, will be going out as well. So Risa, thank you so much for being with us tonight.
Paige, thank you. And thank you all for wanting to know your options, wanting to know that you have choices, and knowing you deserve to have excellent midwifery care, that it's waiting for you.
Thank you, Risa. And we'll also be sending around Risa's contact information and a little bit more about the Lenox Hill program.
Okay. Thank you. God
Thank
bless.
you. Thank you, everybody. Have a great night.